Hello guys, I'm Dr. Meenu, your Obs and Gyne faculty at Medico. So, you know what's so great about Gynec? Aside from the obvious thrills of the job, that is, it is a relatively easy subject. At least the theory part is. So, as you go through the questions, you all know that Gynec is a very high yield topic for your exams. But there are hardly any tricky areas. It is mostly all straightforward. So if you put your mind to it, you'll be able to get 100% score for this subject. Okay? We'll be discussing some previous year questions and more importantly, previous year topics over the next few hours. You'll see what I mean as we go through. So there is a PDF workbook in the description link. Please download it so that you can make your own notes as we progress. With that in mind, let's start with our questions. We have divided this into two. The first part will cover obstetrics and the second part will take up on gynecology. All right. So now we have our first question. Which of the following statements is incorrect? At 8 weeks gestation, the gonad is bipotential. Dihydrotestosterone is necessary for the development of male external genitalia. Mullerian inhibiting substance inhibits the formation of Mullerian ducts. Wolffian duct forms the male internal genitalia. So this is with regard to the embryology. What happens for the primordial germ cells? The primordial germ cells, once they're formed, they are formed in the yolk sac and the endoderm. They migrate through the dorsal mesentery of the hindgut to reach the gonadal bridge. By 6 weeks of gestation, the gonad is no longer bipotential. It only up to 6 weeks is the gonad bipotential. Okay. After that, if the chromosome complement of the embryo is XY, there is a testicular determining factor at the short arm of the Y chromosome, and this leads on to the formation of the testis. The bipotential gonad is transformed into the testis. The testis, you all know, has two types of cells, the Sertoli cells and the Leydig cells. The Sertoli cells produce Mullerian inhibiting substance, also known as the anti-Mullerian hormone. What do these do? See, it is right there in the name itself. It is a Mullerian inhibiting substance. It inhibits the formation of the Mullerian ducts. It causes the regression of the Mullerian ducts. Meanwhile, the Leydig cells produces testosterone, which is the male hormone. The testosterone acts upon the Wolffian ducts, leading to the production of the male internal genitalia. The testosterone is converted into dihydrotestosterone, which is a more potent form of testosterone. The dihydrotestosterone is responsible for the formation of male external genitalia. You get that, right? So from the choices we have at 8 weeks, no, it is no longer bipotential. Dihydrotestosterone is extremely essential for the formation of male external genitalia. Mullerian inhibiting substance inhibits the formation of the Mullerian ducts, and the Wolffian duct form the male internal genitalia. Okay, you always have a doubt whether it is the Mullerian ducts that form the male genitalia, or whether it is the Wolffian ducts that form the male genitalia. See, I've always remembered it this way. Female. The female genitalia are formed from the Mullerian ducts. So we talked about the testis. How is the ovary formed? The ovary, always remember, the formation of the female internal genitalia, the female ovaries, the female gonads is not dependent upon any hormone. In the absence of TDF, that is, in the absence of a Y chromosome, the bipotential gonad automatically converts into the ovary. All right. I hope that is clear. We'll take up the next question. Which protein hormone is secreted by placenta? So you've got some hormones there. The hormone production in pregnancy is actually a bit complicated. Complicated in the sense that there are so many hormones that are needed to support pregnancy. Initially, at least around 6 to 8 weeks, the hormones are produced by the, this one, hormones are produced by the enlarged corpus luteum, the corpus luteum of pregnancy. By 6 weeks, this placenta slowly starts taking over the function of the corpus luteum. Okay, so you got LH, you got FSH, you've got estrogen, you've got progesterone, you've got relaxin. All these are produced by the corpus luteum of pregnancy. But once the placenta takes over the functions, by around 8 weeks, it is the placenta that is responsible for producing the hormones. Here, so one thing you have to remember is that if the woman has to undergo an ovariectomy before her 6th week, the corpus luteum will no longer be there to support the pregnancy and she'll end up having a miscarriage. Here our question is, which is the hormone that is secreted by placenta? Even though so many hormones are secreted, the one that is secreted exclusively by placenta is HCG. This is also the basis of the urine pregnancy test. We are trying to detect HCG. A couple of words about HCG. HCG is, as you know, is a glycoprotein. It has got an alpha subunit. It has got a beta subunit. Now, what you need to know is, it is the beta subunit that is specific to HCG. Okay, the beta subunit is specific, while it shares the alpha subunit with FSH, LH and TSH. Okay, even though the HCG is exclusively produced by the placenta, this is not the most specific hormone that is produced by placenta. The most specific hormone that, if the question was, which is the most specific hormone produced by placenta, your answer should be human placental lactogen. All right. HCG reaches a maximum. It reaches the maximum levels by around 9 weeks. After that, it starts slowly reducing and will reach another. The minimum level is by around 20 weeks. It remains at this level throughout the rest of the pregnancy and it disappears from the maternal urine immediately. That is around 48 hours after delivery. HCG will no longer be found in the maternal urine. Okay. So, here, this is one thing you have to remember. Ovariectomy before the 6th week leads to abortion. Now, so if the woman has got an ovarian torsion or something after her first trimester, or say after 10 weeks, you can easily take out the ovary. It will not be affecting the pregnancy because placenta will take over the function by 8 weeks. Now, this is with regard to the placentation. Placentation is always a favorite topic for the examiners. You might be getting different shapes, different varieties of placenta. You may be asked to identify the placenta. Along with identification, you'll also have to know what are the complications that are associated with this particular placentation. See here, what do you have here? You've got one placenta and you've got a smaller placenta that is linked to it. What is this? This is what is called a succenturiate lobe or placenta succenturiata. In placenta succenturiata, apart from the original lobe of the placenta, there is a smaller lobe that is attached to it. In most cases, you will be able to make this out during ultrasound examinations that are performed antenatally, but sometimes it may be missed. What happens when it is missed? You get the placenta out after delivery, the placenta is delivered out, but then you don't know that there is a small accessory lobe. This lobe may be retained within the uterus. When such a part is retained inside the uterus, it causes a subinvolution of the uterus. The uterus does not contract properly, and because of the retained part, it may lead on to postpartum hemorrhage. That is the most common complication with the succenturiate lobe of the placenta. Okay. This is also a similar picture. You've got one placenta and another lobe attached to it. The difference from the succenturiate placenta is that these lobes are more or less the same size. This is called a placenta bilobate. It has got nearly equally sized discs. This is the third one. You see, it is almost normal. What the problem is, see here, the central portion is missing. This defect can involve the villus tissue and the chorionic plate remains intact. What is the problem here? The placenta is delivered out. You look at the cotyledons, you find something is missing. Now, this might prompt a search for a missing cotyledon. Other than that, not much problems with the fenestrated placenta. This is one that is an examiner favorite, an extracorporeal placenta. This is the usual attachment of the placental disc. Now, here, these are the two varieties of an extracorporeal placenta. The chorionic plate is covered by a single layer of amnion and chorion. This is called a circummarginate insertion. Here, this is the chorionic plate and it is covered by a double layer of amnion and chorion. This is the circumvallate insertion, two different varieties of placenta. What happens? The more common question is, this is the one that is commonly asked, the circumvallate insertion. There is something like a valve that is formed here. But the questions that you might get from this is, what happens? What is the problem if the placenta is like this? Okay. The first one is antepartum hemorrhage. These are the complications of the extracorporeal placenta. You might also go on to have a preterm labor and you might have a growth restricted fetus. These are all complications of extracorporeal placentae. They are of two types, a circummarginate placenta and a circumvallate placenta, where you have got a more thickened double fold of chorion and amnion forming a valve-like structure. The next one, you have a battledore placenta and the velamentous placenta. Battledore placenta, usually the umbilical cord is attached to the center of the placenta. In the battledore placenta, see, the umbilical cord is attached to the side. In velamentous placenta also, there is a marginal insertion of the cord, but rather than inserting directly into the placenta, the cord gets inserted into the membranes. And what happens within the membranes? The cord ramifies. See, all these blood vessels ramify inside the membranes before they enter the placenta. I have also given an ultrasound picture. Here you have the placenta. The cord comes and attaches. This here is the cervix and all the blood vessels are here. They have already ramified, separated into multiple blood vessels before entering the placenta. Now, what is the problem here? This is one placenta with a complication. Usually, when there is an antepartum hemorrhage, be it placenta previa, be it abruption, whatever it is, if there is an antepartum hemorrhage, the bleeding occurs from the maternal side. Here, these are the fetal vessels that go into the placenta. When the os dilates, the vessels on top of the os will start rupturing and antepartum hemorrhage obviously occurs, but the difference is that this bleeding is from the fetus. So unless you take out the baby immediately, the baby may bleed out and die. What is this condition? This condition is called vasa previa. So vasa previa is usually associated with the velamentous insertion of the cord. This is a very favorite topic for the examiners. You remember this. Velamentous insertion of the cord is the one that is associated with vasa previa. Now we have talked about different varieties of placental insertion. There is one other thing we need to know, that is placental tumors. Tumors can occur anywhere in the body. They can occur in the placenta also. The most common placental tumor is the chorioangioma. Cancers that occur in various parts of the body can metastasize to placenta, but there is only one cancer that can metastasize from the placenta to the fetus, which is that it is melanoma. The cancer that metastasizes from placenta to fetus is melanoma. Okay, so that is about placenta. Now we come to the fourth question. A pregnant lady at 32 weeks develops proteinuria and hypertension. The doctor suspects a case of placental insufficiency. What is it due to? Why does placental insufficiency occur? You've got three choices: extravillous cytotrophoblast invasion in spiral artery, villous cytotrophoblast invasion in spiral artery, extravillous cytotrophoblast invasion in luminal artery, all of the above. As we discuss this, I think you may already have studied this, you will know the answer. But as we discuss this, let us just take up the spiral arteries, the arterial system. What are spiral arteries? These are arteries that supply blood to the uterus. The uterine artery goes into the myometrium and becomes this spiral-shaped spiral arteries. These arteries, as pregnancy advances or as the woman becomes pregnant, the spiral arteries are really narrow arteries. These will not support the growing needs of the fetus and the placenta. So, nature has made such an arrangement that as the placenta is formed, certain cells, the extravillous cytotrophoblasts, these cells, they go and invade the walls of the spiral arteries. This invasion takes place in two stages. The first stage of invasion is from 8 to 10 weeks. Invasion occurs up to the decidua. All right. The second stage of invasion is from 16 to 18 weeks, where the cytotrophoblast cell comes and invades the spiral arteries in the myometrium. So, there are two waves of trophoblastic invasion. Which is the trophoblast? The extravillous cytotrophoblasts invade the walls of the spiral arteries. What is the purpose of this? As the trophoblast cells invade, the lumen of the spiral arteries become wider. They are converted from a high resistance, low flow system to a low resistance, high flow system. This is very important to improve the blood supply to the and cater to the growing needs of the fetus. Uteroplacental blood flow is increased. But in certain conditions, say like preeclampsia, this invasion by the extravillous cytotrophoblast cells do not occur. What happens then? When they do not occur, these remain as spiral arteries itself. This results in a low blood flow to the fetus and the placenta. This is the main reason for fetal growth restriction occurring in conditions like hypertension and preeclampsia. Let's just take the question once more. She's 32 weeks. She has got proteinuria and hypertension, that is preeclampsia, placental insufficiency. Why? The simple answer, the cytotrophoblast invasion does not occur in the spiral arteries. Okay. So, there are four things that you need to know. The invasion and transformation we discussed. The arteries are remodeled. Improved blood. This remodeling is for improving the blood flow, and thus placental function is also improved. This does not occur if this extravillous cytotrophoblast invasion is not occurring. What happens? It leads to intrauterine growth restriction of the fetus. Okay. Question number 5. A woman at 26 weeks of gestation presents for routine evaluation. On examination, she's 26 weeks. The fundal height corresponds to 24 weeks. Ultrasound revealed decreased amniotic fluid. Which of the following conditions would have led to this presentation? Now we are coming to abnormalities of the fluid. When a woman comes to you, when you measure the fundal height, you find the fundal height is less than expected. There are two things that you will suspect. Or if the fundal height is more than expected, again two things that you will commonly suspect. First one is the baby is small or the baby is big, as the case may be, and the liquor is reduced. Okay, these are the two things. So here the fundal height corresponds to 24 weeks. Ultrasound has been done. It reveals decreased amniotic fluid. How do you calculate amniotic fluid via ultrasound? You divide the abdomen into 4 quadrants, quadrant 1, 2, 3 and 4, and you measure the single deepest pocket of amniotic fluid, a pocket that is free of the umbilical cord or fetal parts, and then you add all of those together. Normally, this is called the amniotic fluid index, and amniotic fluid index is normally anywhere between 5 to 20. And the single deepest pocket can be between 2 to 8 centimeters. Okay. If the amniotic fluid index AFI is less than 5, or you've got a single deepest pocket of less than 2 centimeters, the woman is said to have oligamnios or oligohydramnios, decreased amniotic fluid. What causes decreased amniotic fluid? There are quite a lot of courses. I'm sure you know all these courses. You might have, you're on mnemonics for all these. See, when you make mnemonics, make sure these are things that you can remember easily. You can keep in your mind. Don't make long sentences. Try to keep it funny or dirty. You'll be able to remember it easier. Okay. I'll tell you what I have remembered. What I've used is, I've used a mnemonic called Dilpar, where D stands for drugs, which are the prostaglandin synthase inhibitors and angiotensin converting enzyme inhibitors. All right, that was a short technical break. We'll come back to our mnemonic, Dilpar. First one was drugs, we talked about it, prostaglandin synthase inhibitors, angiotensin converting enzyme inhibitors. Then you've got diabetes mellitus with vasculopathy. The third D is demise of the fetus, that is intrauterine fetal demise. Okay. Now, I is for idiopathic. L is for leaking. Leaking it can be a pre-labor rupture. It can also be a premature preterm rupture. Then we come to P. P is for post-term pregnancy or also preeclampsia. A is for abruption, chronic abruption, also for amnion nodosum. R is for renal anomalies. All right, so we've got the mnemonic. You have to know that oligamnios may be due to a fetal cause, it can be due to a placental cause, it can be due to maternal cause, it can be due to drugs, it can be idiopathic. Now, if you're asked, what is the most common cause for oligamnios? Your answer is idiopathic. The most common cause. But if the question is, what is the most common cause for severe oligamnios? Your answer should be a renal problem, a congenital anomaly. A renal anomaly is the most common cause for a severe oligamnios. Why? Because you know how amniotic fluid is formed. Amniotic fluid is mainly formed after mid-pregnancy. Amniotic fluid is formed by the fetal urine mainly. What are the renal anomalies that lead on to a reduction in the amniotic fluid? The first one is renal agenesis. Others include a posterior urethral valve or a urethral obstruction. Then you've got bilateral dysplastic kidneys. Urine is not produced. You've also got prune belly syndrome. Okay. So what is the question? Which of the following conditions? It is right there, the first answer, renal agenesis. This is the most common reason for severe oligamnios. What are the complications? There is not enough LICA. What happens? The pregnancy can get miscarried. There may be abortion. There can be prematurity. The baby can die in utero, intrauterine fetal deformities. But the most common complication or the most important complication is pulmonary hypoplasia. This may or may not be associated with Porter's syndrome. You've got meconium staining, you've got a low Apgar scoring. Definitely you will have fetal distress. And then even on the maternal side, the woman may have a prolonged labor or uterine inertia and may have to have increased operative interventions. Now we have discussed oligamnios. So you have an ultrasound picture there. What do you see there? All you can see is the fluid. There are very few fetal parts. There are very few cord parts. It is the fluid mainly. This condition is called hydramnios or polyhydramnios. This happens when the amniotic fluid index is more than 20 or you have got a single deepest pocket that is more than 8 centimeters. Like we discussed, amniotic fluid cycles mainly by the fetal swallowing. Any condition that can interfere with fetal swallowing or any condition that produces more amount of fetal urine will lead on to produce polyhydramnios. Here also, the most common cause for polyhydramnios is idiopathic. Okay. The most common cause of severe polyhydramnios results from what? a defective swallowing, which can be from a gastrointestinal abnormalities. Most common cause of severe polyhydramnios. What are the complications associated? See, here I have given all the causes. Just remember it like if the baby cannot swallow, the baby will have polyhydramnios, as in anencephaly, as in a cleft lip, as in micronathia, as in esophageal atresia or duodenal atresia. All these are conditions that produce defective swallowing leading on to increased fluid. Why I have given this big list is that you just go through it so that you'll have some idea. Okay, you don't have to by heart the whole thing. If you get a choice like say chaos, you must not think what is this, I have not heard about it. It is there. This is a condition that produces polyhydramnios. Just run through your eyes through it, but remember the important ones. All right, what are the complications associated with polyhydramnios? Like I said before, you don't have to mug up all these things. This is not at all tricky. Just think about it. What happens in polyhydramnios? There is a whole lot of liquor. When there is such a huge amount of liquor, what can happen? See, it is a bag that is filled with excess amount of fluid. So, the bag can rupture. She may have a pre-labor rupture of membranes or a preterm pre-labor rupture of membranes. That is the first one. Now, the huge amount of liquor is gushing out all of a sudden. What can come out along with it? She can have a cord prolapse. Because of the sudden reduction in pressure, the placenta can just be dislocated from its insertion. So, she can have an abruption. All these are complications of polyhydramnios. What else? There is a huge amount of liquor and a small baby. The baby can always turn this way or that, leading on to malpresentations. Malpresentations are common with polyhydramnios. What else? These are the common ones that we're discussing. What else? The uterus is over distended. You take out the baby, you take out the placenta. The uterus will take a long time to contract, leading on to postpartum hemorrhage. So these are the common complications associated with polyhydramnios. It is easy to remember, is it not? Okay. Now we have the sixth question. All of the following indicate fetal lung maturity except. Fetal lung maturity is very, very important when you are planning the delivery of a baby, or if a woman presents in preterm labor. The first thing you have to know is whether the lungs of the baby have matured. This is completed by around 34 weeks. How do you know? What are the tests for fetal lung maturity? The most important test is a lecithin sphingomyelin ratio of more than 2. You take out the amniotic fluid and you test for the lecithin and sphingomyelin. It should be more than 2. Another one is increased phosphatidylglycerol. You have the third one, a positive shake test. You've also got blue cells in Nile blue test, and I don't think you may have heard about this. Now, there is something called a Nile blue sulfatase. What happens is you put in the Nile blue dye, when you put it into the amniotic fluid, if there are surfactant containing cells, they are stained blue. What do you get from that? All of these are tests for fetal lung maturity. But what is your answer here? It is the blue cells in blue Nile blue test. Why? Because this test is no longer done. It has become obsolete. We have got better markers to test for fetal lung maturity. So this is no longer done, and hence this is the answer. But if you had a choice that none of the above, you would have to go for that, because all these are tests that are done for fetal lung maturity. One other test that you may not have seen done, or you may not have heard of, is the positive shake test. What is that? It is done on the gastric fluid. While all the other tests are done on amniotic fluid, a positive shake test is done on the gastric fluid. You take it out and you shake it. It is simple. If bubbles are coming up, it means that fetal lung maturity has been achieved. Okay, that is with regard to tests for fetal lung maturity.